Dear colleagues, it is a great honor for us to participate in the International Urology Congress. The topic of my report is venous compression neuropathy syndrome. The aim of the study was to find out how pelvic varices affect the development of pelvic symptoms. For this purpose, from 2015 to 2022, we examined 153 men with pelvic varices aged 18 to 58, mean 33.8 years. The patient examination included numerical rating scale, International Prostatic Symptom Score, the International Index of Erectile Function, the Erection Hardness Score, ultrasound of the scrotum with color Doppler mapping, transrectal ultrasound of the prostate and periprostatic plexus veins, magnetic resonance imaging of the inferior vena cava and pelvic vessels or abdominal and pelvic computed tomography scan with contrast, direct contrast phlebography of the renocaval and iliacaval segments. The results of instrumental diagnostics of the reasons for the development of pelvic varices were as follows. Patients with primary pelvic varices in the amount of 11 people accounted for 2% of cases. Patients with secondary pelvic varices due to arteriovenous conflicts in the amount of 142 people accounted for 98% of cases, wherein the nutcracker syndrome was diagnosed in 49 patients, which accounted for 26% of cases. The posterior nutcracker syndrome was diagnosed in 6 patients, which accounted for 3% of cases. And finally, the May-Thurner syndrome was diagnosed in 133 patients, which constituted the vast majority, and was detected in 71% of cases. Delayed for a minute or more phlebography allowed us to describe the venous anastomotic node of the testicle, consisting of vein testicularis interna, vein testicularis externa, vein cremasterica and vein ductus deferens, wherein, with arteriovenous conflicts of the upper level, I mean the nutcracker syndrome and posterior nutcracker syndrome, and in arteriovenous conflicts of the lower level, I mean the May-Thurner syndrome and its variants, simultaneously develops the dilatation of the gonadal veins, known as scrotal varices or varicocele, and the dilatation of intrapelvic venous plexuses, known as pelvic varices. We studied the presence of pelvic symptoms in patients with pelvic varices, depending on the diameter of the veins, according to transrectal ultrasound and magnetic resonance imaging, using our own classification. Our observations: the frequency of pain increased as the diameter of the prostate veins increased, but pain was noted in 57.5% of cases. Our conclusion: it is not varicose veins give pain. Our assumption is that the pain is caused by compression of the nerves by varicose veins in the fibrous osseous canals known as tunnels. Variant anatomy of fibro-osseous channels, known as tunnels, can explain the fact that with the same dilatation of the pelvic veins, some patients have pelvic symptoms due to nerve compression, while the other patients does not. The presented figures clearly show that even in the same patient, the diameter of the sacral foramens on the left and on the right side is different. With a smaller diameter of the sacral foramens, compression of the nerves by varicose veins is possible, which explains the development of pain syndrome. The observations made during the study allowed us to propose a new term, the venous compression neuropathy syndrome. This is varicose veins in anatomically narrow places, known as tunnels, with compression of the nerves. At the same time, we identified 3 forms of the venous compression neuropathy syndrome: the thoracic form, the lumbar form and the sacral form. The thoracic form includes varicose of the paravertebral veins and Batson venous plexus. Previously, Professor Thomas Scholbach from Leipzig in 2006 described the midline congestion syndrome in the nutcracker phenomenon as the cause of migraine, headache, back and abdominal pain, and functional disorders of the pelvic organs. The lumbar form includes venous compression of the following nerves: nervus ali hypogastricus, nervus ali inguinalis, nervus genitofemoralis, nervus cutaneus femoris lateralis, nervus obturatorius. The compression of these nerves leads to pain in the lower abdomen, in the scrotum, in the area of the outer and inner hips. The sacral form includes venous compression of the following nerves: nervus ischiaticus or piriformis syndrome, nervus cutaneus posterior and nervus pudendus in the Alcock canal or pudendal canal syndrome. The compression of these nerves leads to pain in the sciatic nerve and in the genital area and perineum. Previously, Bensis and co-authors in 2003, Maneker and co-authors in 2004, Chowder and co-authors in 2009, Hu and co-authors in 2010, Di Martino and co-authors in 2014, and Packelt and co-authors in 2018 described the sciatic nerve compression by a gluteal vein varicosity. Moser and co-authors in 2006, Ramirez Garcia and co-authors in 2013 and Passover and co-authors in 2021 described pudendal nerve compression by pelvic varices due to Nutcracker syndrome and May-Thurner syndrome. For the treatment of patients with pelvic varicose veins, we used conservative therapy and surgery. Conservative therapy included the use of diosmin and diclofenac. The surgery included varicocelectomy, endovascular occlusion of the testicular veins, angioplasty and stenting of the iliac veins, endovascular vein occlusion of the prostatic plexus and ligation and resection of the veins of the penis. The angioplasty and stenting of the iliac veins was performed in 104 patients. Within 6 months after the angioplasty and stenting of the iliac veins, there was a decrease or complete disappearance of complaints of pelvic symptoms in most patients. Lower urinary tract symptoms in 85% of cases, chronic pelvic pain syndrome in 84% of cases, erectile dysfunction in 76% of cases, and the disappearance of varicocele in 66.7% of cases. We have studied the dynamics of changes in the mean prostate volume and the mean diameter of the prostatic plexus veins according to transrectal ultrasound data 6 months after angioplasty and stenting in 104 patients. We noted a decrease in the average diameter of the veins of the prostatic plexus to normal. Such changes suggested a decrease in venous compression on the pelvic nerves, which determined the reduction or complete disappearance of pelvic symptoms. How angioplasty and stenting affects the venous plethora of the pelvis can be judged from the presented clinical case. In a patient S, 41 years old with erectile dysfunction and May-Thurner syndrome, computed tomography scan with contrast cavernosography showed a significant decrease in pelvic veins and venous leakage from the cavernous bodies of the penis after angioplasty and stenting of the left common iliac vein. This circumstance allowed us to successfully perform the endovascular prostatic plexus vein occlusion in the future. The International Index of Erectile Function increased from 9 to 19 against a background of the disappearance of pain in the pelvis. The endovascular vein occlusion of the prostatic plexus was performed in 40 patients. The operation was performed for venogenic erectile dysfunction. However, we got unexpected results. Within 6 months after the endovascular vein occlusion of the prostatic plexus, there was a decrease or complete disappearance of complaints of pelvic symptoms, lower urinary tract symptoms in 88% of cases, chronic pelvic pain syndrome in 70% of cases and erectile dysfunction in 73.9% of cases. This circumstance allowed us to expand the indications for the endovascular vein occlusion of the prostatic plexus. Thus, the highly likely causes of chronic pelvic pain syndrome include: firstly, myofascial syndromes as a nerve compression and chronic spasm of the musculoskeletal system; secondly, tunnel syndromes as a compression of nerves in anatomically narrow fibrous and fibro-osseous canals; and thirdly, vasculogenic neuropathies as a compression of nerves by varicose veins. Reflecting on the results obtained, we came to the understanding that angioneurology is a new direction due to an interdisciplinary approach in medicine. Undoubtedly, Further study of compression of the pelvic nerves by dilated veins may provide a clue to understanding many treatment-resistant clinical cases. At the end of my report, on behalf of the team of authors, I would like to thank you for your attention. The study of this problem was carried out by the staff of the Department of Urology with courses Oncology, Radiology, and Andrology of the Faculty of Continuing Medical Education of the People's Friendship University of Russia in Moscow, and by the staff of the Department of Urology of the Autonomous Non-Commercial Organization of Additional Professional Education Center for Medical and Corporate Training in Moscow. Once again, thank you very much.